Hi everyone, my name is Morgan Reinig from the New England QIN-QIO, and I will be moderating today's webinar. Thank you for joining our third webinar in the series for the New England Home Health Collaborative, and today's session is about the use of aspirin in heart disease. Before we get started, I'd like to go over a few housekeeping items. This webinar will be recorded and available within a few business days after the webinar today on our website, and I'll provide you with details on accessing that after the webinar. Phone lines are currently on mute for the rest of the presentation. We will be taking questions at the end, and at that time, I'll let you know how to unmute your line. So at this time, I would normally introduce Kathy Rogie, but she is out today. So Rita Grimes will be filling in for today's webinar. Rita is a project manager for the Home Health Consulting Division of the New England QIN-QIO. So without further ado, here is Rita.
Thank you, Morgan. I'm so delighted to be here for Kathy to talk to you about aspirin in heart disease prevention and management. I want to apologize up front here for the quality of my voice. I'm just coming off a bit of the flu, if one can have a bit of the flu. So let's just move forward.
We are experiencing technical difficulties. Hold on 1 second.
Okay, sorry about that. Let's begin with an overview of the New England Quality Innovative Network Quality Improvement Organization. This is all brought to you by health-centric advisors who focus on the Mass and Rhode Island states, and from Qualidine who focus on Connecticut, New Hampshire, and Vermont. We were left out of the last scope of work by Medicare, but they quickly realized with efforts to reduce rehospitalization that home care was a critical piece in the puzzle. So CMS modified existing state-based QIO programs to create multi-state regions called QIN-QIOs, and essentially pared down their QIO contracts from 53 to 14 QIN-QIO contracts. Really their intent was to provide opportunities for QIOs to share and learn from each other, and pass that on to all of you, encourage all of you to share and learn in order to effectively prevent cardiovascular disease, reduce rehospitalizations, and work with disease at all levels of prevention. Our QIO work in the 6 New England states now administered by health-centric advisors, the Rhode Island QIO, in partnership with Qualidine, the Connecticut QIO, as of August 1st, 2014.
Actually, we're still having some technical difficulties. Jennifer, are you still on the phone?
I'm here.
It's not changing as Rita advances her slides. Do you know why?
Rita, have you clicked on the slides and are you using the page up and page down keys?
Yeah. She is, yes. She has moved it.
Okay, she has the box into right.
Are you able to pull up the PowerPoint that I sent you guys and we can just do it that way?
Was there another set of slides?
I had sent, I think I worked with Emily maybe. I sent the slides over the other day. I'm not sure what's happening. Oh, there we go. I got it.
Okay. So this is yours.
All right, we'll get started again.
Sorry about that. So what I'd like to do is introduce you to the New England QIN-QIO website. It's a new website. Very excited about it. If you can click on that and follow that link, you'll find some exceptional information available to you that talks about not only the New England QIN-QIO and what we can assist you with, but has a great deal of educational programming on it as well. You would simply go to the For Provider tab at the top, and from there drill down to the Home Health section. Okay, good. Still a little delay here, but and you're going to find upcoming events as well as past events that will be archived here, and you can readily access them. Probably more readily than I am sometimes. Also, there's your upcoming events, as well as the presentation materials. We offer free evidence-based resources as part of our improving cardiac health and reducing disparities in care initiative. So again, before we get started, I want to welcome new members to the initiative. And in Connecticut, that would be Home Care Plus. Welcome. Interim Healthcare of North Haven, Utopia Home Care Incorporated. Welcome all. And from Maine, we have Palace Regional Hospital Home Health, as well as Home Health Visiting Nurses of Southern Maine and Professional Home Nursing. In Massachusetts, we have Able Home Health. We have Beata Home Health Care Group Home Health, Home Care, Hallmark Health, DNA and Hospice, Leahy Health at Home, South Coast Visiting Nurse Association, and DNA and Hospice of Cooley Dickinson. And as well, new members to the QIN-QIO in Rhode Island, Brenda Jenkins, and Vermont, Gail Golden, as well as in New Hampshire, Georgette Varelli and Leslie Moeller. So welcome all. Very exciting. Okay, good. So now we're at the point where we're going to delve into the meat of the matter here. We're talking about the role of aspirin in cardiovascular health. And we will review today the best practice intervention package for aspirin in cardiovascular health. Cardiovascular health 1 is really covers, if you get into the BTIP, you'll see this covers aspirin and blood pressure control. And also how you can use this effectively without overwhelming staff. We know that having staff, even scheduling staff to come in for education can be very difficult. So one of our objectives here was to help you to pare it down and make it a workable project. So to begin, let's level the playing field here. And I always like the pre and post thing. So what I'd like to do is just do a few polling questions. And together we can discover what we do know about aspirin and cardiovascular disease and what we may not know about aspirin and cardiovascular disease. So to begin, if we could have the first polling question here. I'm going to read each question to you just so that we're all on the same page together. The first question is, aspirin is a recommended cardiovascular prevention intervention for people without heart disease or stroke. Although the prevention reason differs based upon gender, which pair below matches the correct gender with the correct disease the therapy is attempting to prevent? Is it women for heart attack, men for stroke, B, men for heart attack, women for stroke, or do we just not know? So I'll give you just a few moments here to answer that polling question.
I'm just waiting for the responses from the polling questions now.
Okay, this is wonderful. Many people did not answer. Usually that means that we're really just unsure about either the question or the response. So this is a good opportunity to review what this might, the correct answer is here. I just want to indicate to everyone on the line that these questions and answers are all within the BTIC. This particular question response can be found on page 21 to 23 of the BTIC. But certainly the risk for developing MI and strokes differs between men and women. Men tend to develop coronary artery disease with blockages in the coronary arteries themselves, whereas women tend to develop blockages in the small arteries or tend more towards microvascular disease. So ASA is typically used in men to prevent MI and in women to prevent stroke. So the correct answer there would be D. Thank you. Okay. So the next question is, which of the following groups is aspirin recommended as a primary prevention? Okay. So would it be men age 45 to 79, women age 55 to 79, men and women age 60 or older, or both A and B? So again, we'll give you some moments here to take a stab at it. Okay, so we're just waiting here for the results to come up. Okay, good. So we have the results. Again, 10 of you were a little shy to answer, that's fine. And the majority of you nailed it right on the head, and that is that in both A and D. So it's recommended in men age 45 to 79 and women age 55 and 79. That's in primary prevention. So there's no evidence of disease at this point. And sometimes, for myself, even going back and remembering what's primary, secondary, and tertiary. This is all described for you, again, on page 21 of the BTIC, so that you have that reference when you're training up staff. So good. It is not, what is the problem with C? The problem with C is that it's recommended for men and women who are over age 80 rather than over age 60. So just an FYI here. The next question. Which of the following is the best example of secondary prevention? So we have for options A 50-year-old male with no history of cardiovascular disease taking 81 milligrams of ASA daily. B, a 60-year-old diabetic female taking 81 milligrams ASA daily. C, a 75-year-old male with atrial fibrillation taking warfarin, or D, all of the above. So again, we'll take a stab at it. Okay, so great. Again, let's see here. How did we do? The majority again did not feel comfortable to answer. That's great, that's fine. The correct answer here is in secondary prevention. The best example we can use here would be B, and that is a 60-year-old diabetic female taking 81 milligrams of aspirin daily. And just to remind you that in secondary prevention, the disease has begun but has not yet developed into any clinical signs and symptoms. So in this 60-year-old diabetic female, not yet developed into signs and symptoms of a cardiovascular disease at this point. We're getting there. Number 4, so aspirin should be used as a low dose to reduce risk of adverse reactions. All of the following are potential adverse reactions to aspirin except A, bleeding, B, jaundice, C, dizziness and tetanitis, D, anemia, and decreased iron concentrations. So I'll give you a moment there to reflect on that. Okay, so thank you. Let's see, we have the majority of people selecting the accurate question. Jaundice is not typically seen as an adverse reaction to aspirin, so congratulations to all of you. That particular question can be located in the B tips on page 27. And then the last question is, the following statements are interventions that home health clinicians can assist with the evidence-based aspirin therapy guidelines for their patients except, so here we have an exception. A, screen patients to see if they are at risk for MI or stroke, and if they are currently taking aspirin or antiplatelet as preventative therapy. B, provide education to patients and family about risk factors or MI and strokes and the need to discuss with their physician or advocate for a patient with a physician. C, teach on the medications, adverse events, ways to be adherent with therapy, and when to notify the physician of complications. Or D, do nothing because aspirin therapy is only for primary care settings. So again, we'll take a moment and allow you to take your best stab at that. Wonderful. So again, the majority of people have not answered. However, the correct answer here is D, and you all nailed it who answered. Nothing would be the exception. We all know that we would need to screen patients, to provide education, and to always and ever teach. So, and just an FYI, aspirin is indicated for use in primary, secondary, and tertiary phases of prevention. So you all did great. That information can be found on page 23 through 29 of your VTIP. Thanks. So I don't know. I thought that was fun. You may have been a little bit tortured by it, but thanks for answering those questions. This slide just talks about what the correct answers are, and I would suggest that you can refer to those when you're doing training to your staff as just a quick reference. Okay, good. So one of our goals here was to really give you an action plan if you've selected this particular initiative. It's really quite straightforward in terms of data collection, in terms of education, and how to competency test. We're also going to talk about 3 interventions to improve patient outcomes. So this is your action plan. We're going to talk briefly about each one as we go along. All of these items here are in your DTEX. So please refer to that. If you haven't downloaded it already, go back and look at the information. So in terms of staff education, we're recommending that you perform a pre-test for baseline knowledge, much as we just did today with the polling questions. Certainly there is a pre-test online at the HHQI site that it's more extensive than this, and it's always fun to just do a pre-test and let them compare, what they've learned throughout the session that you'll present. We're recommending that you educate staff on the basic causes of heart disease, on the use of aspirin as a treatment method, how and why it's used, side effects, symptoms of complications. Patient education, we're going to talk a little bit more about that later, and then patient self-management of aspirin therapy. Conclude the education with a post-test for competency, and there you go. We've fulfilled that requirement. Let's talk about interventions. We basically did in the polling questions, but just a little bit more about screening for patients. The screening tools are provided for you at the HHQI website for both MI and stroke, and this should really be part of any education program as well as any assessment performed on the patient in their home environment. There are numerous teaching tools for staff as well as for patients, written in 4th and 6th grade language, or 4th and 5th grade level, and they're good, they're colorful, they draw the eye to the good and basic information. And your teaching plan should always include medications, adverse events, or adverse reactions to aspirin therapy, ways that they might be adherent to the therapy, and when to notify the physician of complications. So there you go. Put that onto your 45 as your teaching plan. Certainly, the VTIP does a great job at risk factors for heart attack and for stroke. Major opportunities here for home health providers to screen. We know that not all people see their primary provider for screening, and we have the advantage and the privilege of seeing patients in their home environment, and that can provide, we can provide screening to patients in a relaxed, comfortable environment where people are more often and more readily and easily engaged in the process. Now, if your clinicians have access to the web, they can pull up the screening tools and engage the patient that way. They can share this with the patient and fill out the questionnaire with the patient. Does wonders for engagement. There are also paper tools available if they do not have web access. So why aspirin therapy? The literature says, and you have in your DPEP, in men between 45 and 79, it helps to reduce the risk of MI and in both men and women over 80 helps to prevent MI and stroke. In particular, in women 55 to 79, it helps to reduce ischemic stroke. So all women post-stroke should be using aspirin unless otherwise not recommended. So these are the latest recommendations for aspirin use. What are the side effects of aspirin? We know GI upset. We often see that in our practice. And it should typically be avoided in a history of ulcer or GI bleeding. If the patient is at risk for bleeding, it may contribute to an increased risk as well as an increased risk for bruising and anemia. And as always, this is a discussion we're having with the physician as well as the patient. Patient education. In patient education, the overall umbrella here is we really want to utilize all those principles of teaching and chronic care management. It's critical that we understand what the goal is at the onset. Typically, this is referred to as the patient's SMART goal. Where do they want to be as a result of this intervention at home with the home care staff? Knowing what their particular goal is can help then you to bridge their goal for the day-to-day health choices they're making. So that, for me, is the challenge. So knowing that they may want to take an unsupervised vacation to the other part of the country, and then tying that to, okay, how can we get you there and how can we get you safely without a rehospitalization? So that's the exciting part of teaching for me. And it really helps them to see the purpose and the consequences of adherence to an aspirin regime, and also for us to really spend the time to explore reasons for non-adherence, and then to address that in the best ways that we can. It's important when we're teaching to really chunk down the information. So how often do we see in teaching plans or in teaching documentation that we taught about cardiovascular disease, for example? Well, we know there's many aspects of that. And I don't know any one patient who could attend to a dissertation on cardiovascular disease in one setting. So we chunk it down into diet, medications, food, and then we allow the patient to chew on that information. So give them time to really look at all that you've presented to them. And then to check back, this is often thought of as teach back. However, here we're talking about checking back to see how effectively you've been able to present the information and to promote that patient's learning. So, all the tools on the HHQI website are available in Spanish as well as English, and there's some excellent teaching tools for that are culturally appropriate. So we have the data extraction tool. All of you who have seen this initiative and this measure. And we know that your data that you've submitted up to CMS, your OASIS data that you've transmitted up, will permit us in this initiative to pull out and extract some of the data. Additionally, you'll transmit at discharge of the patient one additional piece of information for this measure. So very easy in terms of data collection and extraction. This is the one question. That is, did the patient take aspirin or another anti-thrombotic during this episode of care? That's the one question. And just to make a note of it, if selecting is contraindicated, just ensure that and communicate to your clinicians that those indicators for contraindication should be noted somewhere in the record. And here we have it there. We've tried to make the data collection quite easy. We have a bit of a procedure that we recommend that you follow just to expedite data collection here. We're recommending that you include the HHQI ASA literature and all the self-screening for cardiovascular risk in an admission packet for clinicians to readily collect and begin implementation. We also recommend into that admission packet that you insert a data collection tool that you've downloaded from the website so that staff can begin on admission to complete 2 items, which is their name and if they're dually eligible. And then on discharge, they will simply remove that form, answer that one aspirin question, and move that along to a central location wherever in your organization that person sits who will be entering the data in the HHQI cardiovascular data register. This we feel is the most expedient approach to data collection, but again, reflect on how this might work at your particular agency. We recommend that any of you join the Million Hearts campaign, and just to familiarize yourself with it, it's an initiative by the Department of Health and Human Services that began in 2011, the goal being to prevent 1 million heart attacks and strokes by 2017. By participating in this particular QIN-QIO initiative, you are doing that. We ask that you get onto the website there and sign up, be a sponsor. You'll be posted as a sponsor. And then carry that Million Hearts campaign forward into your organization to really increase awareness and help focus everyone's effort on this initiative. So things that you can do are, for example, sponsor some sort of exercise, a noontime walk, just a walk to get some fresh air, not a jog, but just a gentle walk and outside. So exercise, healthy eating, healthy snack options in the vendor machines. Post the Million Hearts logo in very visible places throughout your organization. A bottle of aspirin will help, and a salad might help. These are just some suggestions. But you, I'm sure, have a lot more suggestions. In the spirit of all teach and all learn, we know that you've all been working on this, or you're at least planning to work on this. And we want to invite you to share your experiences, what you feel works or what doesn't work. What have you found that works well or that you find might facilitate this project? If you have a process or a suggestion or any idea that you'd like to share, please do so in the next Q&A session at the end of this presentation. We certainly welcome any and all feedback. And however, I will give a little caveat that if you're not comfortable with sharing online, please do contact and share with your QIN-QIO health consultant for your state so that we can have some good discussion going. I'll remind you that the HHQI Cardio Land provides some excellent support for the cardiac initiative. It meets every third Thursday of the month online, and is an excellent opportunity, again, to share and to learn. The April session We'll look at the role of therapists in cardiovascular care, so I encourage you to sign up and register for that webinar. And if you missed any of the webinars on there, certainly they are all archived and you can get on and listen to the webinars. They're all available to you. So at this point, we have a Q&A session. Please feel free to jump on and make comments and share anything that you might want to share.
So if you do have a question, please press *6 on your phone to unmute your line. Does anybody have a question for Rita? Again, it is *6 to unmute your line. Well, if we have no questions, we can wrap up a few minutes early. I did want to go over a few housekeeping items before you guys hang up. You will receive a follow-up email tomorrow with a link to a brief evaluation about today's webinar. We ask that you please complete this, as your feedback is very important and helps us provide you with meaningful programs. We will include a link to our website where you'll be able to find the presentation, recording, and a transcript of this webinar to share with others that may have missed the call. That link will be sent out in the next invite for our webinar next month on May 16th. That will cover improving physician-clinician communication. So once again, please fill out the evaluation when you receive it tomorrow and be on the lookout for the next invite. Thank you for attending, and thank you, Rita, for filling in today.
Thank you.
And have a wonderful day.
Thank you, everyone.